I don't want to bore you with a lot of statistics. I don't want to bore you with a lot of writing. I want to show you a lot of pictures and a lot of pictures. I want them to stay in your head, and because you will see everything I'm going to show, you will see. You're going to see it one time in your practices. You're going to see, and I'm going to stay away from the rare, some drug therapy, and a focus on, like I'm going to show you, more extrinsic photoaging and skin cancer, because that's how we can help our patients in the best way, in the most practical way possible. That's what we're there to do. Okay? Let us begin. Just two quick slides that I have referenced as a source from the Journal American Academy of Dermatology in terms of their study of psoriasis in the elderly. And they say that by 2025, which is, as I'm aging myself, not too far away, going to be 1 in 4 of our population. So we're going to see a lot of this. We already have sub and subspecialties dealing with this population. And in Europe, soon to be a third. So it's significant. We need to understand what's going on with this population. Okay. One stat that I found very, very interesting was the cost for certain dermatologic diseases. And I thought, okay, it wasn't so bad at $157 million for just cutaneous drug eruptions. Cutaneous drug eruptions, we're going to have a slide on at the end if we have time. That's the number one reason I'm called to the hospital. And they're getting more and more frequent. Number one reason for a hospital consultation are these cutaneous drug eruptions, and it's always an interesting challenge to figure out what the cause is, because they're on a whole myriad of the different chronology that's been introduced out and in the hospital. But interesting. But what's more interesting is $12 billion for skin ulcers and wounds. How many out here are involved in a wound healing center or wound healing clinic? Yeah, it's a few. So it's a growing and already a large industry. And we see already a few people participating. So there are two types. There's intrinsic aging. I'm going to show you photos of intrinsic aging and extrinsic, with the focus, like I said, on mainly UV light exposure and what it can do to the skin. Again, that's the highest percentage of what we're going to see and what is clinically important. Smoking, yes, has effects on the skin, and I can show you pictures of yellow fingers and nails and what it smoked skin, etc. We're not going to do too much with that. And other environmental pollutants, we're going to focus mainly on the UV. And here is a wife of a patient of mine who came to visit the clinic. And as I was walking her back to have a discussion with her and her husband as to the plan for therapy, I looked at her and I said, wow, you would be a great model for my intrinsic aging talk. Because do you mind if I take a picture of you? And she was very flattered. She was very flattered. She was going to be famous. So she took off her glasses, she did her hair, and we took a photo. And as you can see, she does not have one actinic keratosis. She doesn't have one seborrheic keratosis. She barely has a solar lentigo, almost hidden over here. I mean, she's beautiful. And you see the natural laxity, the loss of the infraorbital fat, the blepharochalasis, right? She could use but that's all. Right? So if somebody, and I asked her why, I asked her how did you, you're going to put me out of business if people look like you all the time. And she goes, Dr. Levy, I'm British. We don't like the sun. I said, okay, I understand. Okay. Okay, so here are some non-Brits who do like the sun. Let me take this off here. And you can see what's called here a classic poikiloderma of FAAD, right over here, right? You see right here it cuts off, and all the skin is nice and photoprotected, but right over here on the neck, it's classic, and there are laser treatments, etc. But look at the atrophy. The skin is so thin that you can see the sebaceous glands like a string of pearls down the side, right? We've all seen this. You've all seen this. You know what I'm talking about. Right? So there are treatments for it, but just show what the sun could do just itself over here. You have the solar lentigo over here, an early seborrheic keratosis, and here's another cheek and neck with some actinic keratoses over here, and some really deep folds and rhytids, classic for extrinsically aged skin. Okay. Point number one. Full skin examination, and by full skin I mean complete skin examination. Genitalia, melanoma of the vulva is fatal if we don't look. So we have to look at all the skin, and I'm going to show you pictures of scalp and close to the eye, behind the ear, within the ear photos. Here are, these were growing and bothering him, so we shaved off 3. You can see the epinephrine take over here of these 3 seborrheic keratoses. But here's also a point of a typical picture of, the hyperpigmentation and the thick rhytids, wrinkles in the back of the neck, and then a whole plethora of pigmented lesions here. Is this a melanoma? Is it not a melanoma? We need to look closely, and we're going to show techniques on looking closely. Very important for you also all to give an initial screening. When we're screening there, I say it's like, a mammogram for the breast or a EKG for the heart. We need to look at everything. You have to look at everything in detail and look in a micro way. Compliance in this age group, you know this from your practice, is so challenging. I went to a talk, and Physicians Insurance makes us go once every 3 years. 50% of our patients are going to retain, right, what we tell them in a new diagnosis that we present to them, right? And then they're going to be compliant with another 50%. So 75% chances they're not going to do and not going to understand what we tell them. So what we do is you can use Phone Tree or we use callmall.com, and we make them come back for their full skin examinations if they've had at least a precancer and actinic keratosis, but for sure if they've had a melanoma, basal cell carcinoma, squamous cell carcinoma, and we pull from our schedule into an Excel spreadsheet. The Excel spreadsheet gets emailed online, and they all get called. They call an automatic call. We can call thousands in minutes, voice over IP. And if that doesn't work, then we proceed, and one of our MAs stays late after work because we want to catch them at dinner time between 5 and 7, and they get a personal call, and that also helps, and then they respond to that and schedule them right away. So not just a call into the office. Calling in, we're in front of the computer, we'd like to schedule you right now for your full skin exam. Second, and I find this is significant, I am very technologically oriented, and if you want to reach me, it's really exclusively by text or email. Live is a challenge. The letter, 46 cents I think we're up to nowadays. The letter, getting them a letter also, as a third option, works very, very well. People said, why did you come in? I question them, I query them. What made you come into the clinic today? Was it this call? Was it this aspect? No, I finally got a letter from you guys. So, part 1, part 2 doesn't necessarily work, but the letter really works nicely. Next. We have an operating room in our clinic. We do a lot. We do cosmetic dermatology, we do derm surgery, we do clinical dermatology. We have 2 phototherapy units. We're going to talk about photodynamic therapy. We have aesthetics. So one of the certifying agencies, HHC, American Association of Ambulatory Healthcare, makes us do studies. In order to stay certified, you have to do root cause analyses if there are errors, and you have to do studies that show you're improving your care. So we did these, and I want to share some of these with you because I find them very practical and very useful. One was a practice difference between myself and my associate, Dr. Frederick Rosewater. He would use the iodine swab over here and leave patients wherever he would take a biopsy with a nice brown mark walking out of our clinic on their face. Not elegant, okay? But he wanted ultra sterility, and he would wipe, and then he would do a shave or a punch biopsy and proceed. 50-50, we use an alcohol wipe or not use an alcohol wipe. So I said, is there real value to be that sterile just for a biopsy? And we found that no, there was really no need for an iodine swab for a simple shave or punch biopsy. We followed 800 of my biopsies, 300 in 2009 when we initially were applying for our certification, and there was 0.01% each infection rate. I mean, really way below excision and averages. So we threw out all our swabs. And then we asked the question, no more iodine swab. Sorry, Dr. Rosewater, nope, we're not doing it. Okay? Why swab at all? Is there a value? And I heard in the last lecture, take an alcohol wipe, swipe it, it's like a flu shot, and give them their osteoclast inhibiting factor, 40 or whatever it was. So question is, why swab at all for anything, for a flu shot, for anything? So what we did is we tracked the next 100 biopsies each, punch and shave biopsies. And there was no infection rate. So we saw for 3 or 4 millimeter punch or shave biopsies, I didn't use anything. Dr. Rosewater, we let him have a little swabbing fun and gave him the alcohol wipe at least. And then we still have him around. We still have the alcohol wipes around, but just to prove that it's really not needed. And I will show you some literature that supports this to a large degree. Another pearl I want to share with you is the technique of biopsy. Again, I'm talking about this before, as we scan our patient and we're making a plan for a biopsy, before we get into the nitty-gritty and talk about cutaneous epidermal skin cancers. What technique are we using to biopsy them? This is a half Gillette blade that we use. It's bendable. The more you bend it, the deeper you're going to go. Sometimes we don't bend it at all. We just hold it at either end between the index and thumb and shave flat across. Sometimes we bend. We want to get a bit of that dermis because that's where the pathology is. This Bard Parker or any other brand is dollars. This is pennies. Okay, so I was trained in dermatology, and everybody has a classic 15 blade. By the way, there is, and as I was reviewing my talk, a 15C, sub-small C blade, which is a nice small one for small lesions you can order for your practices as well. But we went ahead and followed these, and also no difference in terms of using a sterile blade, and these are not sterile. They're broken in half. That's what we use for our technique. No infection. So here's a great study by Eisen. And he said, surgeon's garbs and infection control, really, what's the evidence that it really is necessary to cap and gown like we have to do? It's Medicare rules in our Medicare certified ASC, ambulatory surgery facility. We have to do this. We're going to do it, but do you really have to do it? And have studies been done to show that it really prevents infection? He showed. Cap, that we wear those bouffant, lovely blue caps, not necessary. Mask to cover your mouth, absolutely not necessary. Full body covers, not necessary for derm surgery. Are gloves necessary? Yes, but do they have to be sterile? Could we use, we did our own study. We have to do studies, right, to show what we're doing. So we asked, are sterile gloves necessary, or can we pull gloves? Are they sterile enough right out of the latex gloves or vinyl, right out of the box, not sterilized? 97 patients. We did Mohs surgery, we did flaps, grafts, excisions. We wanted to do a multitude of things so it's not biased towards one. You can say, well, only worked for flaps, or it was only simple excisions where it worked. But if you were to do flaps, Dr. Levy, and you were to do Mohs and leave them open for 3 hours, that's where the infection would have been. No, we did everything. 54 sterile, 43 not sterile. 12 patients needed antibiotics because of a valve or below knee infection. There was 1 post-op documented infection only. Sterile gloves cost a lot. So would this apply to vulvar or genital biopsies? The ear, the genital area is a dirty area, considered a dirty, technically, a lot of infection. We operated everywhere. We operate skin cancers on the ear all the time. We did with just plain gloves, non-sterile gloves, no higher rate of infection. It's not that invasive. If you have somebody that's not immunosuppressed, not on cyclosporin and mycophenolate mofetil, and they're a transplant patient and on a biologic, and they're, obviously in that case, that's a different scenario. I'm talking any one of us sitting here comes in and needs a simple 3 millimeter, 4 millimeter punch or a shave biopsy. You don't have to have a super expensive sterile blade. You can use this little simple Gillette shaver. You don't have to iodine. You don't have to alcohol. Because they're small, limited procedures. Now, in the groin area, I've taken out huge, seborrheic keratoses, and in those cases, yes, based on size and area, one has to use one's good judgment. Nothing is 100% or always in medicine. So here is a study from the JAD, Journal of American Academy of Dermatology, a prospective study of wound infection in Mohs microfracture surgery using clean, not sterile, surgical technique in the absence of prophylactic antibiotics. If you give them prophylactic antibiotics, like we said, they're American Heart Association cases, that obviously is going to neutralize. These are cases that did not need them, and this was just for and I will show you this pictorially soon. These were just cases of opening up the skin for Mohs surgery, right? Just opening up that skin, not the closures. The closure we use sterile technique, okay? Less than 1% infection rate versus the average in other studies, an average of 2.5%, 3% in this one. And if this is Elie Levy's article, yes, over here, 1,000 cases of Mohs. These are 1,000 cases. Questions? Are we all good? Okay. Still haven't seen basal cell or squamous cell yet, right? Our patient we're not there. We're not there. Patient is coming to us, right? It's coming to us. We've decided, where there's a lesion in front of us, to stop or not stop anticoagulants prior to cutaneous surgery has taken a lot of interest starting about 10 years ago in the literature. Most of the data comes from the cardio and anesthesia literature, but it has been looked at for cutaneous surgery in the skin literature, okay? And here you have an article, I know David Kriegel, 2011 in March, and here's the issue. What are the risks of bleeding complications, right, with continuing their antiplatelet therapy? Daxa, even their aspirin, warfarin, etc., against the risk of thrombotic complications associated with stopping their platelet therapy. Right? What's the question? When do we stop their warfarin? When do we not? Then they have to restart again, and then they have to test and PT, their levels. It's hard to get back into the groove again. They have multiple surgeries, so do we stop? And they come back in 2 weeks. We do another procedure. They have to stop again and start again. It's a challenge. So conclusion, risk of bleeding is minimal in dermatologic procedures. Minor, certainly in yours also. You do excisions in your practice, in your clinic, okay? So know that the risk of bleeding is minimal. Okay, and minor compared with the rare life-threatening risk of cardiovascular complications with stopping their antiplatelet therapy. So for years now, 8 to 10 years easily, I want to know if they're on warfarin. I want to know if they're on an antiplatelet drug, if they're on Plavix or one of those categories of drugs. Okay, if I'm working near a temple artery, I want to know that they're on it. I'm gonna gauge what I'm gonna do. I'm not saying forget about it. I don't care what they're on. I'm gonna ask them if they're on the G's, ginkgo, ginseng, all of those things, because it will, contribute to their bleeding. But I don't stop them anymore. It's very, very rare that I'll stop a patient, take them off their warfarin, or take them off their Pradaxa for even a flap or a graft procedure, and you'll see them. I'll show them to you. Okay, here we are. We're getting there. Here we are. Cutaneous epidermal carcinomata, and I emphasize epidermal because, again, each one of these can be hours. You can do a seminar on each one of these in terms of the data and literature and how far we want to go talking about these. So I'm just talking about, I want you to know what can happen in the epidermis. We have the actinic keratosis, the precancer, basal cell carcinoma, squamous cell carcinoma, and melanoma. I will show you photos and make select points. If you have questions, please ask, and I will stay as long as you want afterward to answer questions. The dermis contains a whole other cadre of structures, and they're very rare. An apocrine carcinoma or choriocarcinoma or leiomyosarcoma exist. They're rare. We're not going to see them in daily clinical life, and that's what my talk is emphasizing. So what do they think? Okay, here's a JAD article, May 2012. What do they think in terms of them getting a skin cancer, our older adult population? And what this shows is that prior to reading this, I would have thought that they're extremely educated. They're extremely savvy. They have iPhones, they have iPads, they're on the internet all the time, much more time than we have. They're extremely, extremely educated. But no, their perceived risk for having a skin cancer was much lower than others. And we need to know that when they come in, they don't think, and seeing you for whatever reason, even if you see them for a wound ulcer, they don't think that they're subject to getting these. So all the more reason for a full skin examination, all the more reason to educate the population. Okay, so here we are going to finally get some pictures of dermatology, and here is a little ulcer in the mid-rim of the left lower eyelid. You can see the age over here, and beautiful blue eye. And it's a basal cell carcinoma. Okay, it's not a hortelium, it's not a chalazion, it's not a nevus, it's not a little seborrheic keratosis. Our index of suspicion has to be high, and this needs to be biopsied. It needs to be, Mohs surgery needs to be performed here to ensure the cancer never recurs, and we're going to go into the details of that. And there's going to have to be some kind of oculoplastic reconstruction. Here we go again, right? Nice, classically photo-aged skin. But right over here, you can say, hey, this is a little folliculitis, it's a pimple, it's nothing, it's part of the rosacea. not going to do anything about it. See you in 6 months. We're going to take care of other things today. No, this is a basal cell carcinoma, early small nodular basal cell carcinoma, pearly telangiectatic papule with it has a little hyperkeratosis there, a little ulcer in the center. This is an Australian middle-aged gentleman who came to see my astute PA, Andrea. He came for a rash on his face. He had a rash on his face. Okay, analyze, prescribe. And so I train myself and my PAs to ask them to take off their shirt. If they're coming to you anyways, it just takes 10 seconds. Please, ma'am, sir, if you don't mind, we'd like to do a small above waist, at least skin exam on you. It's not a full skin exam, admittedly, but at least above the waist. He takes off his shirt, and this is what we find. Unbeknownst to him. No idea whatsoever, right? What is this? You have a rolled border. You have some pigment, so it's a pigmented subtype. It's clearly a scarring subtype, a very, very extensive, deep. And the defect here, when we did the Mohs, I mean, it was all the way out to here. All the way out to here. I had to send him to plastics to do a flap to cover that. But that's a basal cell carcinoma. Sclerotic basal cell carcinoma, just indolent. He didn't feel it, didn't notice it, not bothering him. Another example of a superficial BCC, patient's going to come in and you see again a little sequelae of photo damage, a little hyperpigmentation over here, feel a little early seborrheic keratoses, some solar lentigos, hypopigmentation, hyperpigmentation, the rhytids that are setting in, the wrinkles that are setting in. And over here looks like a little nothing. Okay, give him a little Bactroban, take 2 Bactroban and call me in the morning. And then go, put a little bit of Neosporin on it and think, oh, okay, put a little hydrogen peroxide. No, this is a superficial BCC. Stretch the skin, touch the skin, feel it. Might feel harder. Stretch it. Put the light, side light it. That'll be pearly. Here's a classic nodular basal cell carcinoma right over here. They love to hang out and invade along the rhytids. And here's the superior left glabellar furrow over here. And there's our Mohs defect. The initial one was here, right? And then it actually extended subclinically under here. So we had to take another section here, right? And I tried to do it in the way that it would follow along his natural skin fold. So when we closed it, it would be a nice thin line. It'd be, mostly unnoticeable. I will show you some before and after pictures of these later. This is a gentleman in his late 60s, still working away, has had multiple facial basal cell squamous cell carcinomas. He's had a 5-FU treatment for his face for diffuse actinic keratoses, and just recently presents to the clinic for his routine every 6-month full skin examination. And what do we find? We find, a little nothing here. It's just a little pimple or something in the middle of his neck. Well, take a look at the surrounding areas. I've tried to emphasize. Look at all the photo damage over here. Look at the deep furrows and rhytids. This is called cutis rhomboidalis nuchae. Cutis rhomboidalis nuchae. And if you stretch the skin, it looked a little bit pearly. You see it's a little bit elevated, a little elevation papular here, certainly over here. This is an invasive basal cell carcinoma. The defect over here is going to be at least this large, the sutures are going to go from here to here. Because when they occur along a natural fold, skin cleavage, just say on the side of the alar rim or the ridge, they like to go deep. They like to invade vertically instead of superficially. So they're not all your classic, round telangiectatic papule. I'm not showing you that. You know that. You can find that in the books. This is a lovely woman who came in 3 times with her husband, who himself had 3 Mohs surgeries. And then I believe while she was watching the before and after pictures that we have of the monitors and the screens inside of the exam room, said, hey, by the way, can you take a look at this? What's this? So one could think of a melanoma, but indeed this was a pigmented basal cell carcinoma. And the emphasis here is the hair will thin with time. Not a lot of people wear hats, and to look inside of the scalp and inside of the hairline, you can still get a skin cancer there. They're not going to always be very obvious and very large and sticking right out. You've got to look inside of the scalp as well. And we have another such case here, where again, look everywhere. right? This is hardly noticeable. Maybe she hit her head, right? She hit her head in cabinet, raising thing. Over here, you can see the crust. This is a little closer up photo over here. And then you see the scar, the pearly telangiectasia. We had to zip her up with staples from here all the way down. I mean, the defect here was huge, because it was there for a long time, and it just went unnoticed. And what's interesting about this case, I talked to her, and I asked her, I was asking my patient, why you? Why does this patient have hypertension? Why does this patient have this and that? Why are they developing that? Why did this specific tumor occur here? She said she would go and winter in Arizona a lot. She would winter in Arizona, and she would wear a visor. Right, okay. So I was like, okay, now it makes sense, right? Everything covered but this. So the sun will penetrate. With time, your hair is going to thin, and you're going to get enough sun photo damage that you're going to develop one of these. You're not going to see it. It's not going to be overtly in front of you, but you are going to be able to pick it up because you're going to look through scalps now, go through scalp hair. This is a shaved area from his goatee that extended all the way out to here. This was shaved. You can see their hairs growing out of here, right? And this was a small little papular nodular basal cell carcinoma, right? Hidden, again, in a hair-bearing area. Again, one needs to be astute. We performed a Mohs surgery on this and took it out. And interestingly, he has another lesion I'm going to show you later as well. This is a woman who came back for a routine full skin examination. And I had spotted this on the last one, noted it, and said I was going to follow it. I was a little gun shy, a little biopsy shy, blade shy, 6 months ago when she came in. But then it came back and I was like, something's bothering me about this. I stretched the skin, I put the light on it, and it wasn't, it was not typical. And you look on this bed of phenomenal photo damage, right? Hypopigmentation, atrophy, the skin is really, really rough. This is a superficial basal cell carcinoma. Yeah, so. And it's large. This is big. This is what we see clinically is about right over here, but subclinically this extends all over the place. So excision with right underneath. Yeah, absolutely underneath. Yeah, we go straight all the way down to the fat, sometimes to the fascia when we excise these and when we close these. Here's an example of Bowen's disease. You'll see, left side, right? Left side of the body, more skin cancers. We're going to show you a slide on that. And looks like nothing. And you might neglect somebody who's so hairy. I will say the best sunscreen is hair. If you got hair, it's going to protect you, a lot. But it's not, nothing is 100%. And this is a squamous cell carcinoma in situ. He came in, and he comes in when he wants to come in. He came in, this is a medic, an intelligence officer in Vietnam who knows everything and knows how to handle himself and his skincare as well. So he came and he had like 4 basal cell and squamous cells from all the photo damage he's experienced in his life living in the South and traveling all over the world as a consultant. And he came in for an excision, large 10-centimeter excision over his deltoid over here. At the same time, he says, hey, doc, why don't you take a look at these? So now I'm contradicting myself because for little biopsies, I told you we don't use iodine. But when we do multiple ones and I'm operating on his shoulder, I said, I had my swab on me anyways. Let me swab these guys. And all were hyperkeratotic, erythematous, scaly, papules and plaques, all squamous cell carcinoma in situ. Right? I mean, so 1, 2, 3, 4, all at the same time. It's a therapeutic challenge, How are we going to go? We're going to cut each one of these out. Can we use other techniques? We're going to talk about photodynamic therapy as an option soon. And here's the classic squamous cell carcinoma, right? You see the hypopigmentation, atrophy, and he was having trouble shaving. He said he would shave it and it would bleed, shave it and bleed. And you could see the hairs. He wasn't able to get to it after a while. And here's a squamous cell carcinoma right over there, just as an example. So this is Benny. Benny, as you can see, has had easily 30 to 40 procedures with us over the last decade. Okay? And that's it. He just keeps making precancers and skin cancers. We're going to talk about a drug later on that we put him on to suppress some of this. But meanwhile, you can see over here it's a little hypopigmented scar and the ear's a little bit turned in from a Mohs surgery, and a graft from a basal cell. Over here, you can see a thin line and of a scar tissue from an excision and a Mohs surgery and closure for a squamous cell cancer. I just want to point out that there's an 11% metastasis rate of metastasis for squamous cell carcinoma, which he has here on his ear, okay, from the ear, and there's a 14% rate on the lip. You don't see his lips, but they're there. And one has to be vigilant. One has to be vigilant when it comes to the areas of the ear and the lip. You know, you may feel it, touch it. Don't just pull out your cryo and freeze it and say goodbye and it's not going away. If it's not going away, it needs to be biopsied. You need to see what is engendering all this keratin. You see this cutaneous horn here? See the horn coming out of the skin? You could have actinic keratosis under there. You can have seborrheic, you can have a squamous cell carcinoma, you can have basal cell carcinoma, you can have all kinds of cells that are mutated, whose genes are mutated, that are engendering all this keratin. But this is atypical. You shouldn't have all this keratin being produced, so you have to go and chase it. Just a few quick slides on location. As we were speaking about the ear and the lip, I want to point out that there is an article that shows that indeed more on the left than on the right side of men, this is only men, not women, are where skin cancers are going to appear. And I will show you a photo soon also of malignant melanoma in situ also appearing. So point being, we're taught and we tend to examine patients from the right. Right? You stand on the right. You're always examining a patient, we're talking medical school, on the right. No, you have to examine them everywhere. I'll do 1 or 2 revolutions around the exam table. You know, get on my knee. I always tell them, I'm getting on my hands and knees for you. You know, get on my hands and knees, whatever it takes to look at all angles and all aspects of the skin. Next. We are going to see more and more tattoos as time goes by and our population enters the post-65 zone, and we have to be really, really vigilant again in such cases, right? You see a phenomenal amount of sun damage over here, right? This is a surfer. And where I circled right over here and right over here, I mean, if I take the black away and I uncircle it, could easily be missed. You're not going to get a lot on the field because these are superficial basal cell carcinoma. They're not nodular. You won't feel a knot. You won't feel some collagen that's being bound or elastin that's built up around it, or some mucin in a cystic basal cell carcinoma being built up around these. These feel like rough, scaly actinic keratoses. That's what they feel like. You just have to be vigilant to stretch the skin, side light it, look for that pearly, look for the telangiectasia, biopsy it. You know, it's not that expensive, and it's not good to miss something because you're not biopsying it. So these are 2 superficial BCCs, and we try, when we excise them, again, to preserve as much of the tattoo as possible. So what I do is I excise the borders first, make sure it's clear, and then make it so that it's a smaller. No, I don't just randomly take wide margins, because some of them have a lot of meaning to the patients. Melanoma in situ. We spoke about this before in terms of the gentleman who had all the seborrheic keratoses on his back. Well, here you have a back, right? Phenomenal amount of solar lentigos all over the place. And he has a few little, maybe flat junctional nevi. And this one caught my attention. And we performed a punch excision, and this was melanoma in situ. If you didn't take this now, what's going to happen in 3 years? Poor prognosis as this grows. Breslau thickness, every millimeter it grows. If I could send a message home, if it's really, really dark, if it's jet black, and it has some jet black dark component to it, which these have much, much less of, right? The darker the color is the main feature of the melanoma. Now, on an ER physician in our hospital, I found an amelanotic melanoma, okay? They can trick you sometimes, but very, very rare. We're just talking about what usually 90% of what comes in is dark features. So, and here's a gentleman on the lower back, lesion growing and growing and growing, neglected to come in, and now is already nodular melanoma. He's alive and well, but this has gone too far. This has gone too far. And here's your, again, left-sided lentigo maligna. Just what we do is, when they come in for this, just to show you that you might think this is big, we take a Woods lamp, okay, and we look through a Woods lamp and magnification, And the borders on this lesion, no exaggeration, are going to go under his eye, out to the front of his ear, all the way down here. This is how far they can extend subclinically. And even Mohs surgery isn't a panacea in terms of curing such patients. After we do the Mohs, actually, I will use a topical chemotherapy afterwards to clean it up and make sure all the cells are killed and gone. And we'll talk about that. Excuse me one moment. If they've had a melanoma, they do have an increased risk of basal carcinoma and squamous cell carcinoma, 12%, incidence of another cutaneous cancer within a 5-year follow-up. Okay? And I'm showing you these two cases because over here, in this gentleman over here, yeah, okay, cute, small cutaneous horn actinic keratosis, freeze, goodbye, a little telangiectasia. And over here, I looked in, I did not biopsy it, I didn't do anything with it, and I'm sorry it's a little dark. This is a seborrheic keratosis. But over here, in this 55-year-old gentleman that just sold his company for $60 million that he inherited from his father, said, hey doc, remember you looked at this last time? I went back and I looked and I said, yeah, you know, that looks like it's growing. This is a melanoma in the conchoid bowl of the ear. This was the same gentleman, and it hurts, you know, when you take that and you have to let it heal. The cartilage there really hurts a lot, you know, after post-excision. He's the one who had the basal cell carcinoma in the goatee area that we showed before. So here you go. Melanoma, he had a basal cell carcinoma, he has a history of actinic keratoses and basal cell carcinoma. They hobnob together. When you have this photo damage, it's indiscriminate. So think of everything, look for everything, look in odd places. So here's what tuned me in to that, me biopsying that more than just letting it go, is my dermatoscope. This has saved me doing so many biopsies because they look dark and ugly and really, really bad, and oh my God, what am I going to do here? Take 10 of these lesions off the patient? So I go and inspect them, and there are books written on this dermoscopy, or otherwise known as dermatoscopy, either way. Books written on the features one sees under 10x. And this you can use without oil, which is nice, because in the earlier dermatoscopes, they were longer, a little more bulky to deal with, and you had to put oil on to get these images, and now you don't have to. And there's polarized light pushing on this button, and on the other side, non-polarized light, 48 LED bulbs that shine in on the point, and you can inspect nicely. So if you have any questions in your clinic, biopsy it if it's really dark. And it appears, you know, it has the A, B, C, D, E phenomena going on. But if you're not sure and there are a lot of lesions, send them to us. We'll do a closer inspection and may not need to do a biopsy. Okay, moving on to our actinic keratoses over here, the precancer. We alluded to and saw, you know, photos of before. I want to emphasize that you should all invest in one of these. Several companies make them. And you can call your distributors for this. This is the smaller version. I used to have the longer, taller ones. They went to about here, but I didn't need to fill them up that much, and a lot of cryogen would go wasted. A lot of liquid nitrogen would go wasted. So get the smaller one, easier to handle. They make them with a base now, so they're not falling as much, and same price, but just easier to handle. It's accurate. It's cheap. Use cryotherapy for actinic keratoses. I say use this because I'm alluding to therapies that should not be used and be less used. And these are our topicals. Here you have, you know, classic actinic keratosis on the dorsum of the hand over here. Kind of liked his ring, so it made a nice photo. The topicals are 5-fluorouracil. It comes in a 0.5%, 1%, or 5% formulation. I've tended in the past to use the 5%. Don't think you need to go that strong. It hurts. Anybody use 5-FU on their patients on any regular basis, or topical 5-FU? No? Okay, good. It's good that you don't. Then you have the imiquimod, which is I'll have a slide for coming up right after this explaining the mechanism of action. You have an NSAID, topical NSAID. I don't believe in this at all. You have a new one, which is a 2-3 day plant derivative called Picato, $800. The tubes are this big. Okay, you get 2 tubes, $800. Just ridiculous. Of course, you use trichloroacetic acid, alpha-hydroxy acid, tretinoin. The imiquimod works by stimulating TNF-alpha, interferons, and interleukins. And I only want to mention it because I did mention it. It has a lot of uses. There's a lot of data, a lot of literature on, we know that came out for condylomata, but can use for actinic keratoses, squamous cell carcinoma in situ, even superficial and nodular basal cell carcinoma. In certain cases, maybe where surgery is not an option. Okay? Lentigo malignant melanoma, as I mentioned before, I'll use it, always use it even after surgery as a double, as an extra to clear up cells that surgery may have missed. And even studies on Kaposi sarcoma, and I show you that there's a new formulation here that's has less than the 5%. These are 2.5 to 3.75, so you have less reaction. This causes a phenomenal, as you'll see, reaction in the skin, and it's really, really painful. This is 5FU just after 5 days. And we came back, usually we don't see them, you come back to the clinic complaining of a lot of pain. So we have to either give them some topical steroids, Tylenol, some Advil, along with their treatment right from the get-go because it's really painful. So the question is, are topicals worthwhile to treat cutaneous cancer? Right? So you have this archives article from 2009 that looked at imiquimod that we just spoke about and fluorouracil that we saw photos of for basal and squamous cell carcinoma, a systematic review. They had high rates of adverse effects, lower clearance rates than other treatment modalities. That's not what we want. Dependence on patient adherence to treatment. How many of our patient population here are really going to strictly stick to this? And higher, much higher cost, as I mentioned, than other therapies. Okay, so where is this really worthwhile? I think there is a role for them, but much more limited than, certainly not our go-to therapy for these reasons and on this basis. We've come to use photodynamic therapy a lot because it's a one-shot deal. They come into the clinic, they sit for an hour after we apply 5-amino levulinic acid, 20%, over the area to be treated. A lot of bald men, scalps, a lot of scalps with diffuse actinic keratoses. How are you going to take that little can and go push, and freeze every single one of those? They're so diffuse all over the face, all over the scalp, all over the hands, all over the forearms. So we've gone to this and had a phenomenal amount of success because it's a one-stop shop, and I have over here covered by Medicare. You don't need pre-authorization. That's the first question. What is this going to cost? Am I going to have to pay out of pocket? Nope, no pre-authorization needed. It's covered by Medicare. They cover the supply of the drug and the treatment. So we apply it to the areas that need treatment, face, scalp usually, dorsum of the hands, forearms at times. They sit in a chair for 1,000 seconds, what was chosen in the study, so about 17 minutes. And they walk out. We give them a hat, a wide brim hat to wear, tell them to be careful in the sun for the next 48 hours because they're still sensitized to the sun. This patient over here didn't listen. Okay? So as you can see over here, we treated him on Thursday and he came in on Monday saying that he went and did his yard and was out in the sun, a few weeks ago when the sun was out in Seattle. As you can see, he wore a cap, right? And over here, this is the normal reaction that you're going to have a few days later. But over here, he really got burned. And that was, we have to be careful. He admitted it was his own fault, but he had to come in, put him on some oral antibiotics. We were afraid he'd have some community-acquired MRSA here or something, oral antibiotics, topical steroids in combination. But 7 days later, he came back and look. From all this to this. It's pretty impressive. I was very impressive, enough to take a photo and keep it and show it, Really, you don't see them. I follow them up like a month later, and I didn't realize you can get, their results. They peel very quickly, Whereas if you're going to do the 5FU, it's a minimum 2 to 6 week treatment, and they're suffering throughout. So this is one. Okay, zap. You're going to have 2, 3 days, 4 days of peeling. Stay out of the sun, and then all should go well. I want to highlight also, we're talking about actinic keratosis. There's an entity of actinic cheilitis, where the whole lower lip, you see the vermilion border is kind of lost. It's not a crisp border anymore. And it's rough, scaly over here. And you can't take, and I was just talking to my PA, you can't take your liquid nitrogen, and without any anesthesia, no mental blocks, go ahead and freeze this whole lip. We do mental blocks and some local, and we take a CO2 laser and we just zip the whole lip and they grow a whole new nice lip. This is the drug therapy conference, and there is a drug for these actinic keratoses and squamous cell carcinomata and basal cell carcinomata, and I'm going to point out another one soon. But this is used largely as a preventive. Acitretin is a retinoid. It's a vitamin A derivative medication, kind of like Retin A that we use for acne. Same category. We're all familiar with that. So this is the pill form of Retin A, you might think. And it comes in these dosages. And many studies have been done in transplant patients where they're so immunosuppressed that they're developing squamous cell carcinomas every month. There's even an entity called transplant hand, because it affects the dorsum of the hand, where they just remove all the skin on the dorsum of the hand and graft it with skin from another area of their bodies because it's out of control. So I have patients, and you will see patients with such severe photo damage, and they develop squamous cell carcinoma or basal cell carcinoma every few weeks or every month, every few months. Several times a year they're in for something, and they're like lizards. Their skin is really, really weathered from. They're like a total actinic keratosis. What do you do? So I will put them on this drug. In analogy, it's not FDA approved for this, but in analogy to them, I consider them immunosuppressed because they're making so many of these cancers. They're clinically immunosuppressed. So I'll treat them like a transplant patient. I'll put them on the same drug, and the incidence of their cancers plummets tremendously. Just want to make you aware of it. So I want to take a few minutes because I think most people, like when I gave this talk in the past, aren't familiar with what exactly happens with Mohs surgery. And I think, number one, it's a liability if you don't refer for it because there's a high rate of recurrence if one is not going to refer for the Mohs surgery technique. And it's cost saving, and we'll see slides and data on that. What are the criteria for Mohs surgery? It's for areas of tissue sparing, and here are the areas of tissue sparing: the periorbital area, the nose, right? The ear. We don't have a lot of ear to give away. We want to minimize the amount of lip that we're going to cut out. Lower extremities, fingers and toes, right? Nail bed matrix. Squamous cell carcinoma can occur in the nail bed matrix. Genitalia, alluded to before, and the temple scalp area. Those are the main areas for tissue sparing, right? Continued criteria: size, larger than 2 centimeters. It could be small, it could be maybe half a centimeter, but the pathology is really, really aggressive. It's a sclerotic or it's an invasive basal cell carcinoma. I would say basal squamous cell carcinoma. You'd want to Mohs it because we don't know how far the tentacles are spreading. You have syndromic. There are people that basal cell nevus syndrome that develop basal cells, and then you have recurrent ones, post-excision or elective desiccation and curettage. I discourage elective desiccation and curettage a lot. They always come back. It's hard really to get proper margins and to scrape deep enough into the skin to get all the tumor out of a basal or squamous cell with this technique. And it can occur in burn scars. If they occur in a burn scar, you don't know where in the scar tumor is hiding, so you have to do the Mohs technique. So I'm just going to take you step by step through what we do and how it's done. Here's our tumor. This is a biopsied tumor, so there was a little more elevated than this. And that's how they're going to be referred to us mostly. We make our Nick North, and then I look at the anatomy in the area, and I'm already trying to predict where is the closure going to occur. How am I going to close this right from the beginning so I can guide my Mohs and guide my margins so we hide this right in his furrow. Here's his right furrow, here's his left furrow, right over here so it's not seen. So there's our 1 to 2 millimeter border. I dot the tumor itself, and then I take 1 to 2 millimeters around. There's our nick in the skin for north, so we preserve orientation, which is key. We take it out, put it on a napkin. The patient's data is on the napkin. And we can submit it whole, but we submit it split because it's easier for the histologist to process. Okay? We split it into two. We use any colors you want, but we use blue on top, blue sky, orange earth, red earth, and there's our defect. We started here, And there's our defect, and off the tissue goes to the histologist. We have a lab in the clinic. We process our regular shave, punch, biopsies, and excisions. And then we have a small area dedicated to the staining and the processing in the cryostat here of frozen section Mohs surgery. And within 30 minutes, we have our results. Okay? The results come on here. 4 angstroms of width are each of these sections over here on the slide. You have a side A, you have a side B, and that's me. Looking at the slides, just want to make everybody aware. Looking at the slides, here are our slides. We look over here at the slides and we analyze. And I don't have a huge fancy microscope with the camera in it or anything, so I took my camera and I put it above a lens, and there you go. That's what it looks like. So we're looking for any extrusion over here. This is your epidermis right over here. Here's the sebaceous gland. Here's the dermis. There's the orange dye, a little bit of blue dye on top. Maybe you can see it, maybe not. And there's our side A, a slice of our side A with the epidermis on this side. Side B is going to be on this side. And we section it like a bread loaf all the way through and make sure there are 4 clear sides, 4 clear sections without any tumor. If we need to, we go back. So here are just 2 cases. One is a left temple basal carcinoma, sclerotic subtype. So, much more, this one is indurated. Whoever asked if we can feel this before, this you can feel, because there's a lot of scar tissue that is engendered by the cytokines of the basal carcinoma itself. So you could feel this. But you might look over this in your patients. Again, I'm trying to point out the subtleties of this. Might say, oh, he has a little dent, he hit himself, a little scratch, back to bed again. No, this is a basal carcinoma, and that's our defect. Here's the original section, right? We took out this much, but then he went 2 stages. So we had to take more of it going this way, deep and superficial. And then you can see over here, we have to extend it superiorly and all around this way. We go back, right? We started here, and here we are. And then there's our closure. And we try to make it, as much in the hair, extend the scar in the hair as possible. Case 2. This is I'm embarrassed to say, a nursing home resident who we followed for many, many years. She comes in a wheelchair, refuses a full skin examination. I should have forced her to take off her shirt. She finally came in because it was getting annoying that this thing was staining her blouses. Right? So finally this bled enough that she presented to the clinic because it was staining her blouses. And here's our defect. Right? All the way down to muscle, is striated muscle here. And we got it in one go. Again, all the classic signs of photo damage. You find the signs of photo damage, you're going to look and see, is there a basal cell around? Is there a squamous cell around? Is there a melanoma around? She has such lax skin, it could just undermine over here and lift it up, Is it cost effective? There's studies that honestly say it's questionable, but this one says that yes, because it has the highest initial cure rates, lowest recurrence rates, and lower cost than surgical excision. There's their reference. One must be careful when we operate on them. I'm going to speed up here a little bit because they can bruise a lot. And sometimes they are so thin, we can't even put subcuticular sutures in. It's so thin. We just put in nylon sutures, some glue, and off they go. Bye-bye Mohs. New drug has come out earlier this year, and I've had the opportunity and would love to show you a case where I've actually had the opportunity to use it. It's not common. Why? Because I don't wait. You're not going to come to me. I'm not going to get to the point of advanced BCC as a dermatologist. As you see, I want to catch these at 2 millimeters. We're not going to wait for things to get as big as the lady on the back. But they will present us, as you saw. They will present us. And maybe an option now is to take a pill instead of doing all this radical surgery. Maybe this will become more standard of care. Look, this is amazing. I'm actually chills every time I look at these slides. This is a 91-year-old Russian immigrant gentleman. Doesn't speak English. Comes with his son who speaks a broken English. Okay, and this is getting annoying again because it's bleeding and staining his pillowcase. And the wife is sick and tired of washing pillowcases. Okay, this is the true reason for motivation. Now, mind you, look in here. There's a hole already. Okay, it's already invaded back here. This is the anterior right earlobe, posterior right earlobe. It tracks into the ear canal. all the way up into the ear canal. This is 6 months after the Elie Levy. Now the question is, there's a lot of scar tissue here. Is there any tumor residual there still or not? One doesn't know, and there's no endpoint to treatment. They said it's like a chemo drug. You keep giving it until you do a test. So we probably would do just a little mini punch biopsy here, which are not scar, it's already a scarred area anyways, and test just to make sure that it's all gone. But this may become standard of care, Obamacare coming and need to cut healthcare costs. Nope, sorry, we're not going to give you the Mohs surgery. We're not going to do excision. There's not going to be a facility fee. You're going to give them Elie Levy. Goodbye, done. If they have 2 or 3 of them, like the gentleman with all this, squamous cell carcinoma in situ on his chest, maybe this would be an option. There have been great advances in metastatic melanoma. I just want to mention these 2 drugs, BRAF inhibitor called vemurafenib, IB for inhibitor, and then you have the MABs, the monoclonal antibodies. I was fascinated to see there's a monoclonal antibody for the osteoporosis. So a lot more coming out. It's a human monoclonal antibody, not non-human. And patient of mine that had metastatic melanoma, we often have to refer to oncology, received 6 weeks of this IV. This is a pill. This is a pill that they take, so it's not IV. And it's melted away metastatic tumors. Just a couple notes on common dermatoses, xerosis, and psoriasis. I just want to mention at the end here. And number one for patient presentation is for dry skin, dry itchy skin. So our goal is to enhance the barrier, strengthen, protect, even enhance the appearance, right? And I always say, and I'll just take this message out of this slide, is just go to the dollar store, buy a jar of Vaseline, and put it on once a day. Maybe this should be protocol in nursing homes, especially from the knees to the ankles, where a lot of the winter itch and the xerosis is going to appear. Go to the dollar store, buy a can of Vaseline, and just put it on once a day. Make me happy. Come visit us. We have a lovely clinic, a beautiful Japanese-themed clinic in Burien. Please come and visit me. I'm here for questions. Thank you. Thank you.